screen and then we can start. All right. Can we see my screen?
Not yet.
Is it showing now?
No.
No. Okay. Uh, sorry. I think. I'm so sorry. I'm just going to look for it. So I'm going to stop sharing for a bit. Can we see my screen now?
Yes.
Yes. Okay.
Yes, we
Thank
can.
you. Sorry, I'm just disabled with IT sort of things. All right. So my name is Omomi. I'm a GP trainee here in the UK. Thank you so much for having me on this platform to give this talk on attention deficit hyperactivity disorder, which we know as ADHD. Before I start, I just want to say I attended I'm going to try and keep this as informal as possible. I know we're in a very formal setting, but it's a Sunday evening. I'm going to try and keep it informal so we can have a good time as well. I attended a meeting recently, and then one of the things I took away from the meeting was the fact that we all have one form of disability or the other. That the fact that we tend to class some people as having disability doesn't mean we are perfect. We live in a fallen world, so none of us is as perfect as God actually intended us to be. Some people are just on more extreme and is apparent that they don't conform to the standards that the rest of us have set. Doesn't mean that we are that much better than them. Just putting it out there, because I will give some example of some of the symptoms here and what I've seen and how I think it's just a spectrum really. It's just the extreme of things, and not that these symptoms are not, they are not, they are going to be seen in many of us. That's what I'm trying to say. So let me just start by, so we're going to be talking about introduction, symptoms, diagnosis, conditions that are similar to ADHD, and available treatment options. So in terms of introduction, what do we mean by ADHD? So when we're talking about definition for ADHD, it can be defined as a persistent, emphasis on the persistent pattern of inattentive, hyperactivity, and impulsivity symptoms, and that they should affect general functioning, social functioning, and development. So let's remember they are persistent. They are not one-off. They don't just occur once in a while. There has to be a pattern of it happening. And who gets it? It happens both in boys and girls. However, when it comes to girls, girls get to be underdiagnosed, and this is because girls present more with the inattentive symptoms, whilst boys present more with hyperactivity, impulsivity symptoms. Meaning, girls, the symptoms seem to be more subtle in girls, whereas boys are in your face, and whatever is in our face, we tend to get help, we tend to seek diagnosis for. And then boys too sometimes have conduct disorder associated with it, meaning that it's more likely they get diagnosed and get treated, whilst the girls maybe find means to cope with it or stuff like that. Also, we have it both in children and in adults. In terms of in adults, some adults get their diagnosis missed whilst they are children. They don't get to have anybody give them a diagnosis, and they can now have that diagnosis in their adulthood or as they are getting older. And for some people, they've had their diagnosis from childhood and it persists into adulthood. And also some of the symptoms get better whilst we see the hyperactivity, impulsivity symptoms tending to get better with age, the inattentive symptoms can persist. It's quite common. So if we say 3 to 4 people in 100 people having ADHD, I think that's a fairly common condition. In terms of what causes it, we can't say this is exactly the cause for ADHD. There's no known cause. However, there are a lot of factors that come into play. So we have genetic factors, we have environmental factors. Genetic factors mean that they've not mapped one particular gene to causing it. But if you have somebody in a family having ADHD, there's a higher chance that somebody else in that family can have ADHD. It doesn't mean it definitely will happen. It just increases the likelihood. For environmental factors, so you have a child that was born with low birth weight. Someone was born preterm. There's maternal exposure to alcohol in pregnancy. There's smoking in pregnancy. There's lead exposure, or we have iron deficiency anemia. Those are some of the risk factors that can be associated with ADHD. They don't necessarily have to cause it. It's just an interplay of all of that with genetic factors, predisposition to having it can make it happen in some individuals. Now, when we're talking about symptoms, like I was saying earlier, that we all have one form of disability or the other. It's just what have we discovered that we are not able to do. I just want to say that, so some of these symptoms we'll be looking at. Like I was going through these symptoms and I was just laughing that, oh yes, I think I have this. I think I have that. I don't think I paid attention long enough. But is it a persistent pattern? I would say no. Has it stopped me from normal development, from social functioning? I would say no. So we have to put everything together into context. And this is because in my practice, the things I've seen that differentiates somebody from our background, a Black, Asian, minority person, from people with a more British background, is that we tend to not seek diagnosis. We tend to not seek help. We tend to do, God forbid, we tend to do, nah, it's not my portion, my child doesn't have that. And what does that mean is, at the end of the day, we don't get the help on time. Whereas a good number of our friends that are more British background tend to want to find a label for things. They just want to snack a label on somebody and say, this is what the problem is, so somebody else can deal with it. So it's just trying to find a balance. We don't want to be on the extreme of we are not getting help, we're not getting diagnosis right. And we don't also want to be on the extreme of we just want to label something so that we can push the problem away. So we want to know if this is present. Are these symptoms present in my child, in the person I'm giving care to? Does this child need help? So we'll talk about some of these symptoms now. So you have a child, you have a ward that is not giving close attention to details or making careless mistakes in the work, in the assignments, in the little things. And lest I forget, in talking about these symptoms as well, especially for the younger children, we want to map it to their ability. So for instance, you've gone to church, you are expected to sit down and listen to sermon for 1 hour, and your 3-year-old wants to run around. I should assume that is normal for your 3-year-old after 10, 15 minutes of sitting down to say they want to go play. It's about, are we mapping the symptoms age appropriate, or are we just expecting them to do things that the adults are going to be doing? So we should not forget that in saying, oh, this child is just not sitting still. I wouldn't want to sit still. For me personally, I wouldn't listen to a lecture for more than 15 minutes because maybe it's because they just don't put all the learning, the materials I need at the same time. I want both auditory and visual at once. And some people are just good with visual, some people are just good with auditory. So it's mapping all of that together. Also, not forgetting that if a child is having visual impairment or having auditory impairment, we can't just label them with having ADHD. We have to make sure we've ruled out the obvious. We've taken on board the fact that they can hear properly, they can see properly. There's nothing wrong with them. A child that wants to pee all the time, have we made sure it is not UTI? It's not something making them not want to sit still? before we say this is definitely what is going on. So let's go back to the symptoms. So if you having a child that is having difficulty concentrating, performing tasks, that could also be a symptom of ADHD. But like I've been saying, it's so this particular child doesn't like a particular activity. It's different from they just cannot concentrate with all activity. We should be able to make sure that it is not a problem with just one activity. It's not that they just dislike, they don't want to do something. It's not that they are just being disobedient to one thing. It's that they just cannot concentrate long enough to perform tasks. I mean, if a child is appearing not to listen, like as if their mind has wandered off, and there's no obvious distraction, that could be a symptom of ADHD. They have difficulty in organizing tasks and activity, and easily distracted by extraneous stimuli. And what do we mean by extraneous stimuli? So you have a car honking. Most of us will ignore that kind of sound. You have your fan making noise in the background. You have your fridge making noise in the background. Most of us will ignore those kind of stimuli. But a child with problems with inattention would want to solve that, and they get distracted by that kind of stimuli, and they just want to attend to it before coming back to their task. They have reluctance, dislike, or avoidance of tasks that require sustained mental effort. I would say here, it's funny, when I was growing up, my dad tried to teach me how to play chess, but chess was too much mental effort for me. So, but I enjoyed playing Scrabble. So if you tell me to play chess, I would not play chess because it was just too much mental effort. But I'll play Scrabble. And some people will say Scrabble is also sustained mental effort. So I'm just putting that there to say, is it that the child just doesn't like that particular effort? Or does it cut across board that they just don't want to do anything that is going to require their mental ability? And then failure to follow through on instructions or finish a task, losing items easily. You send your child to school with 5 pencils, they come back with 0. The next day you send with another 3 pencils, they come back with maybe 1. Or they pick something that is not theirs, and it's just easy distractibility, forgetting to do what they are supposed to do. Those can be symptoms of inattention. We could also have symptoms of hyperactivity or impulsivity. Now, when we talk about hyperactivity or impulsivity, so a child cannot sit still. They are fidgeting. They are tapping their hands or feet or screaming when seated. And I mentioned earlier that we must map it with their age, with what we're expecting them to do at that time in their development. So we should not be expecting someone to sit still when after 10, 15 minutes, they should be taking body break. A child leaving the seat when remaining seated is expected, such as in the classroom. Running about or climbing in situations where it's inappropriate. Maybe you clearly explained, we are going somewhere, I would like you to sit still, we are going to visit a friend, just stay in one place, play with the phone, and then your child wants to start running about, climbing all over their furniture. That might be inappropriate in that situation. Also having inability to play or engage in leisurely activities quietly. So they just want to be heard, they want to be making noise, they want to be everywhere. I mean, you might have seen children that are on the go. It seems as if something is driving them. There's just too much energy. They're constantly behaving like as if there's boundless energy in their body. That could be a symptom of hyperactivity. Talking excessively, not wanting to shut up, wanting to say something before even the question is being finished. So a child blotting out an answer, you've not even finished asking the question. It could be a sign. Difficulty waiting his or her turn, or interrupting or intruding on others. Now, in terms of making diagnoses, here in the UK, the GPs are not allowed to make a diagnosis. So what happens is a patient or the wards or the caregivers come to us and say, they've noticed this, that in this child. So we take on board everything they've said, we listen to the complaints, we note it down, we try and make sure that it fits into the criteria, which I'll talk about shortly. And then we make referral to the appropriate authorities. The treatment, the diagnosis, initiating of treatments is with the specialist. So what we do is just we partner with all the specialists and make sure there's a smooth running of things going on in the background. But when it comes to treating, to making diagnosis, it's not in the hands of the GP, but we are the portal. We are the ones that take on board what has been said and pass it on to the specialist. But before we can pass it on, there are a few things that we feel has to be present according to the guidelines. So we want it to be, so these symptoms must have been there for at least 6 months. They should be present in more than one setting. So a child has been having these symptoms at home, but is not in school, not in other social settings, then it's not likely to be ADHD. We want it to be in at least 2 or more settings. So for instance, it happens at home, it happens in school. And then in that situation, we want the school report, report from the school nurses or that kind of report, just so that it can corroborate the facts that we're being told. If it's for an adult, we also want reports, say in work situations, in social settings, to say it's happened in more than one setting. And the symptoms should have started before the age of 12. It should interfere with the quality of functioning. So is it interfering with social functioning? Is it interfering with academic functioning? Is it interfering with work? And also, it must not be explained by another condition. We'll talk about some conditions that can happen alongside ADHD or can be similar to ADHD in terms of presentation. So we don't want these symptoms to be explained exclusively by another condition or to have occurred in the time of psychotic disorder. Those are some of the things that we want to think about when we're making a diagnosis before we refer to the specialist. Now, in terms of conditions that can occur in similar, I can imagine that some of us would have been asking, how is ADHD different from autism? They are very similar. It can be quite hard to differentiate, and most of the time we leave that work to the specialist to do. The symptoms are the symptoms of not being able to function in social settings. They can be the same. So, like when it comes to tantrums, in both settings, children can display tantrums, but the tantrum of ADHD is more because they cannot concentrate, whereas the tantrum of autism could be more because somebody has disorganized their usual pattern. So they've got a schedule to do things, and there's a kind of disorganization at play, and that's why they are throwing tantrum. So, but to differentiate ADHD and autism is not going to just be easy like that. The symptoms really overlap, and we leave that in the hands of specialists to do. There are other common conditions that can also occur either alongside with ADHD or could be the reason the child is presenting with that. So a child having anxiety. With anxiety, there can be fidgeting, there can be nervousness, and they can, because of all that, they might find it difficult to sit still. They might be tapping their feet. They might want to walk off the anxiety. When it comes to depression can lead to poor concentration, inattentiveness, and that can present in the same way as inattentive symptoms. With substance use, we can have mood swings, it can impair social functioning, occupational functioning. We can also have somebody with conduct disorder, but we have to know that in conduct disorder, they have no regard for consequences. As regards somebody with ADHD, that is not, that should be part of it, except the conduct disorder is also occurring alongside with the ADHD. In oppositional defiant disorder, they tend to lose their temper, they're argumentative, they blame others for their mistakes, and they refuse to comply with rules. So it can occur alongside, but it's also different. We also have to keep in mind that condition like seizure, especially absence seizure. In absence seizure, there's no shaking of hands or legs like we commonly know with seizure. With absence seizure, somebody can just go blank. And in that period of time, it could seem as if they are inattentive. But that is the issue at hand there is the seizure, and not because of ADHD. It's just to keep that in mind. Now, let's talk about what is available as treatment option. So somebody comes to me, the GP, It depends on whether the symptoms are mild or they are severe. If we've got somebody with mild symptoms and they are able to function, we can advise for watchful waiting for up to 10 weeks and encourage self-help measures, simple behavioral management. I mean, if somebody, if you know that a child cannot sit still for long, we want to get different activities that will keep their mind occupied and just swapping the activities around, just kind of simple behavioral management. We offer referral to group-based focus support. Now, for the children, we refer them to CAMS, which is the Child and Adolescent Mental Health Team. They are the ones that make diagnosis, like I said, they take on board everything that has been said. Then they can start treatment if treatment is necessary. There are medications that we can use to make things better. But like we all know, everything has side effects. They won't decide to use medication except they feel it's appropriate and it's going to help. Also, they could offer CBT alongside with medication, either after medication has not helped or if they think the patient needs it as well. But it is in the hands of the specialist team, really. For adults, they are referred to psychiatric team. So the adults can be referred based on either they already had a diagnosis from childhood and they are now adults and they just need continuation of the treatment, or they could be referred because symptoms are just being picked up and they need a diagnosis. Right. So that's in summary talked about the symptoms of ADHD, what we are supposed to look out for, how we get around to making a diagnosis, what support we can offer here. I might not be able to talk much about the support because it's a specialist management area, but support is available. If we think we have a child, we have a ward with some of these symptoms, please let us speak to whosoever is in charge. If you're in the UK, speak to your GP. If you're outside the UK, I know it might be challenging, especially if you're in Nigeria, to find help, but speak to your pediatrician. Keep speaking until somebody thinks, yes, they want to look more into what's going on. Right, I hope I've been able to open our minds a little bit on what ADHD is about and what we can do to help. We'll be taking questions, I think, after the second speaker speaks.
Yes.
Thank you.
Thank you so much, Dr. Umi. Thank you for opening our eyes to what ADHD is, and thank you for letting us know that there can be comorbidity, other things. So we should not jump to the conclusion that this child has ADHD. Thank you very much. We're going to move quickly to our next speaker. Our next speaker, she's a lecturer, a teacher, and she deals mainly with people that has a kind of disability. So we're going to be seeing how can we support our children if we notice any of this, hyperactivity, inattention disorder. I know that in some parts of the world, you beat that child, you force that child to sit down, you force that child to learn physics, chemistry, biology, even if they are struggling. And sometimes it's not really their fault. It's just the way their brain works. And if they don't get the appropriate treatment, it's going to be struggle. So without wasting our time, I'm going to invite Mrs. Kemi Ajose, my big sister, to please.
No, what's up with
And I just say big sister.
You're welcome. Somebody is speaking under there. Please, can you mute yourself?
I mean, for example, hello, good afternoon, everyone.
Good afternoon.
Be with you this evening. Like the first speaker said, we want us to be relaxed.
Focus. So I'm going to focus.
Someone is speaking. Can you please mute yourself? Now, I would like to introduce myself. My name is Kemi Ajose, and I'm a lecturer in a college. I've taught in secondary school before, I moved to further education college in UK. So I'll be speaking with, the experience that I had when I was in secondary education and as well as in college, because in college we deal with 16 to 18 years old as well as adults. That is 19 plus to 100. So I'll be talking about ADHD this evening, looking at the educational aspect of ADHD on our students. So I will start by doing a brief preamble into what Wumi started with, Dr. Wumi. So I will go into the tips for supporting persons with ADHD. Now, before I move into any discussion, I want you to have a look at this image on the screen. What can you tell me about the image? I want you to answer the question in the chat button, and I want everybody to take part in it. Looking at this image, what is the image telling you? What are your thoughts on this image? I would like you to use the chat box to answer the questions. And I would like the host to be reading out the answers.
Okay.
So that we can have idea of what is in the chat box. I can only see my PowerPoint. I can't see the comment people have put in.
Okay.
So looking at this image, I want everybody to look at it attentively and then give me an idea of what you think the image is talking about. What are your thoughts?
Could you please okay.
Can people put information in the chat box? Host?
Yes, they can.
Okay.
The child looks confused. The child is expressing a confused mind.
Thank you. Any more?
Child looks sad.
Good. I want more, please.
My head feels heavy.
Anything else?
The child looks creative.
Good. Okay, I will move on.
Depressed, unhappy, child under pressure.
Yes, I like that keyword. The child unhappy, the child under pressure. That is exactly what the image is talking about. It's like you are having too much going on for you, and you cannot concentrate on anything.
Bizarre looking. You have another one, bizarre looking.
Okay, thank you. So we'll go back to the chat box after I finish my presentation. Thank you for that, the host. Now, I will start with ADHD as being categorized as part of mental health and well-being. And that was why I said, look at that image and let me have your thoughts. Because it's categorized as part of mental well-being, mental health. According to World Health Organization, we were told that mental health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And if you look at the image I've put with this definition, it's still talking about everything going on for someone at one particular point in time. There's anxiety, there's negativity, there's stress, there's chaos. Things are not just going as it should go. And then the next one is mental health can be described as the strength and capacity of our minds to grow and develop, to be able to overcome difficulties and challenges, and to make the most of our abilities and opportunities. So if you can look at the image beside the text, it's having all sorts going on as well, and is crying for help. So when we have a child with ADHD, it's like so many things going on. There, as the doctor said, it's subtle in the ladies, in the girls, and the gentlemen and the boys. You can see them hopping and jumping all over the place. They are restless. And we as parents, we always find it difficult, especially the minority here in UK, that is the Black and the Asian ethnic minority. We we don't, want our child to have anything. We say we rebuke it, we refuse it. But the truth is there, and we refuse to see the truth because of the stigma that is attached to it and the language that people use when they talk about mental health. That can also contribute to why people feel they cannot come out to say that their child is having this problem. Please help us. In the classroom, we have children with different mental ability, with different mental well-being. I'm using the word mental health and mental well-being. If you look at this mental health continuum, you could see that here we have the maximum mental well-being, where a person with a diagnosis of a serious mental health illness can cope well and has positive mental well-being. And then we have another person that has no diagnosis here at this axis, a person with no diagnosis, mental health or disorder, but who has very bad and poor mental well-being. That is also not a good one. So this continuum here is telling us, if we look at it, we could see that we have the serious diagnosis, the minimum mental well-being, we have no diagnosis, then we have the maximum mental well-being. So mental well-being and mental health are very important. We are all having this in our life, one way or the other, is very fluid. It changes. It exists in us, either we like it or not, at any given point in time. It's either we are on maximum mental health well-being or we are on minimum mental well-being or we are in a serious diagnosis situation. But whatever be the case, at any point in time, we all have this. It is very fluid and it is forever changing. So when we have students that comes into the class with ADHD, they come in with what we call EHCP. In UK, the official term is hyperkinetic disorder. In America, it's called attention deficiency hyperactivity disorder. In classroom, we have to use different strategies to be able to work with our students so that they can excel. The strategies can be in two ways. We have what is called behavioral classroom management, and we have the organizational training management. These two strategies required trained staff, and that is why we, the lecturers or the classroom teachers, we are trained when we do our CPD on how to support our learners in the classroom. We were trained to be able to give them that maximum support so that they can excel whatever their situation is. Because we have students that have so many issues, not just ADHD. We have counselors in the college or in the schools that can counsel and support the learners. We also have the college psychologists. All these specialists, they work together because we are just in the classroom to teach our learners. We are not specialists, but we have all these support staff with us to help us to be able to help our learners in the classroom. Now, when we look at the behavioral classroom management approach, this one, if properly managed, helps the learner to be able to sit down to be able to do their work, to be able to manage their engagement in the classroom, that so that they are not looked at as being destructive. So this behavioral management approach has been tested in primary school, and we in the secondary as well as the colleges, we use them. And sometimes we give them breaks in the classroom to make sure that they are able to concentrate when they are fidgeting. We tell them this is time for your break. Do you want to go around? So you can excuse them from the classroom, and then they go around for 5 or 10 minutes, and they come back into the classroom to come and do their work. Now I'm talking in terms of a college, because now I'm a lecturer in the college. But in the primary school, you cannot allow kids to be going around and walking around. So in that situation, they give them stress relief activities, toys, coloring, something that they enjoy doing, so that they can concentrate and get that break before they come back to do their probably maths or English. Now, we also have the organizational training, where we teach the learner in the classroom how to manage their time, how to plan, and the ways that they can keep their materials organized without disrupting or disturbing other learners in the classroom, and how we can help them to reduce distraction. In young adults in the college, one thing you find out is when they have their phone, instead of them using their phone to do the work, they'll be using it to go online to do something probably they enjoy doing in the class. So you've got to learn how to monitor them in the classroom, how to draw them back into what you want them to do in the classroom. Now, how can we help? As I said before, we say they come to the college because we are not specialists. They will have met the specialist, they will have given them a plan. In UK, we call it EHCP. Some people call it IEP. EHCP means Education Healthcare Plan. IEP means Individual Education Plan. So this plan, they will tell us their situation. We will read it, and that is what we will use to support them in the classroom. You could see the image here that the lady is doing one-to-one. Most times, you have to create one-to-one with them in the classroom to be able to manage their ADHD. Also, um, tips that we use in the classroom is communication. If you look at the image here, you can see that this stylon that is not medicated is just all over the place. The one that is medicated, that has the EHCP, that is being monitored and support, will be calm, will be sensitive, and then will be able to do what they're expected to do in the classroom. Communication is very important. You need to communicate with them. You need to let them know what you want them to do at any point in time. And you do not run them down. You need to give them that self-esteem that they can do it, they can achieve. And then if you are going to change anything in their routines, you need to let them know. You need to let them have that opportunity so that they can be familiar with the new situation you are introducing them into. For example, timetable. If you want to change their timetable, you need to let them know things are changing, things are moving, and then they can come on board with you and adjust. And then you need to give them positive feedback. You need to encourage them. Like I said, their phone can be used constructively to do things that you want them to do in the classroom instead of going online to solve. And then you need to communicate and ask them if they are fidgeting. Do you want to go for a break? So sometimes they don't ask. You can ask them and say, Will you like to go for your break now?" So that they can be calmed down. Now, there's what is called reasonable adjustment, and that has to do with activity that you give them in the classroom. When we say reasonable adjustment, that means we give them tasks. In college, they have to do coursework, and then you give it to them. If you don't monitor them, they don't do it, and that means they don't achieve. So how do you help them to achieve? So we will say we need to make reasonable adjustments. Reasonable adjustment means the assignment brief that you have designed in the classroom for coursework. You will need to make sure that it's clear. They will understand it in their own language. You've broken it down into bits, not give it to them as a chunk. So you lay it out step by step so that they'll be able to do the work that they want to do. And then you make sure that the assignment is not too long for them. You make it very, very short so that they can be able to read it. You can do something like online quiz for them. You can do hands-on. Some of them are very good with hands-on. So instead of just writing report, you make them to do practical activities so you can observe them doing it. Most of them, they like to use their hands to do things that they like or they enjoy doing. So you can do that for them, breaking their work down in chunks and then allowing time for exercise, move around in the classroom. They can get up and move around within the classroom without allowing them to leave the classroom so as to minimize distraction. And then you need to create a folder for them, homework folder, so that you can use it to track what they are doing. And then you help them by setting them reminders on what to do and how to do it. And you have to give them that extra support in the classroom if you really want them to achieve. And that is part of what we call reasonable adjustment. What you think is normal might not be normal, for them. So you need to adjust the assignment brief, coursework, task into bits that they can chew. So for parents, uh, we cannot do it without the parents. We work together with parents and with support within the college. And that was why I put this image that says parent education and support before leaving. Um, some parents, if they are even up to adults, if they are going to uni, they will make lists of what their child that has been experiencing ADHD needs to do, what they need to remember when they are in uni. Now, how best can we advocate for our children, or how best can you advocate for your child? We as parents, as I said at the beginning, we tend to run away from I rebook it. It's not my portion. We don't face up to reality. We need to understand our child's situation and the impact on their education. We need to sit down and look at how can we help that child to achieve, how can we support that child to move on with life as normal. The EHCP or IEP will be done by the specialist because the GP or whoever, because if you complain that your child is hyperactive, your child can't do this, they are having that trend of the situation or of whatever the support they need. You have a specialist. They will sit down, they will look at the child, you will go for appointments, and then they will give you that EHCP plan. And sometimes it's done with local authority as well. So at that point in time, if you have any questions, you ask them. You shouldn't be afraid to ask questions because you want to help your child and make life easier for your child, uh, you know, so that things are not, jumbled together. The child is confused. You are confused. You don't know what to do. You must know your rights. You have every right to ask, and you have every right to support your child. You have every right to work with teachers, to work with lecturers for the best, for your child. So every parent should know that there's good support in the college, in the secondary, in the primary. We have different services that the government have laid down to support parents. And this play a very active role in preparing your child for their education. A resource guide for educators, so people like me, is there. There's a resource guide for us on how to support our learners that has come into the classroom with different situations. And then we have the healthcare providers. They play a very, very major role in collaborating and working with schools, with colleges, with local authority to make sure that your child get the best services for that will help him to thrive in any environment. So please, you need to know all these things. You need to know where to go to. You need to know where to turn to. You need to ask questions. Even you need to be calling your teachers, lecturers, or teachers to ask how that child is progressing. You yourself, you need to sit down. You could see the image I've put here of a lady sitting in front of a laptop. You should you should be able to search about the situation and get information that you can use to help that child, not just looking for support, but how you can support that child in the house. Now, before I round up, I want to talk about practical experiences. When I was in secondary school, I have students that they have the ADHD. They come into classroom with their plan, we support them. What we can only do is the support that will help them to thrive in the classroom. And then we have other supports in the school. If the child is restless, they want to have break, so we call for the support. They take the child out of the classroom, to go and chill out, to calm down. Then they bring that child back to join the others because we do not want segregation where one child will feel not part of the team or not part of the group, so that they can all learn together and see themselves as normal. In college, we tend to allow the 16 to 18 years old to go out by themselves, to walk, to come back, because you can't leave your classroom and they are old enough to go out and take that break. That is very important. Also, um, a person 16 to 18-year-old with ADHD, as I said before, will make sure that we give maximum support by breaking down the work. Some things you think others can do in a different way, you will do it in a different way with them. You can interview them instead of writing coursework. You can discuss with them and record it as evidence so that they can get their grade. Most importantly, parents must be able to work with teachers, because if that child has not achieved what he's supposed to do or she is supposed to do in the classroom, you set it as homework so that that child goes home, and then the mom or the dad at home can now support that child to complete their activity so that they don't lose out. So for now, I will say that we parents, we need to work with teachers and we need to work with the specialists so that we can help and support our children. Question time. Do we have questions?
Thank you very much, Ma. Thank you so much. We are thoroughly blessed. Please,
Amen.
if you have any question for Dr. Wumi and Mrs. Ajose, please kindly put it in the chat box so that our questions can be read out. In the meantime, I have a few questions that I would like to ask our two speakers. Yeah, thank you so much. The first question will go to Dr. Wumi. You were talking about different specialists. I know some people may be watching us from countries where their own is just that I want to go and see a doctor. Like we know that in the UK, you go first of all to go and see your GP, and the GP makes referral. But there are some countries that, oh, I just want to go and see a doctor. So please, can you explain to us what type of, this group of specialists that I'll be looking for if I have a child that is hyperactive, a child that I notice that is restless, a child that I know that forgets things easily? What are the type of people that I'll be looking for. Thank you so much.
Thank you for the question. So here in the UK, the general practitioners, the GPs, are the gateway to the healthcare system. We are the first port of call. So if someone notices their child or their ward is having ADHD symptoms, either they or the school can come to us and tell us, we've noticed this and that, and then we make the referral. So we make referral to the psychiatry team. For the children's psychiatry team, they are called CAMS here in the UK. It's Child and Adolescent Mental Health Team. For the adults, we just make referral to the adult psychiatry team. And within those teams, they then have other specialists as well that will work with the children. They would have psychologists like Mrs. Ajosi has mentioned. You have the educational people that will support. The school health people are also there to support. So there are different levels to the specialist team. But when it comes to the core clinical specialist team, is we the GPs that make referral to the psychiatry team, and the psychiatry team would then assess the child, assess the adult, and decide who else needs to come on board, who else do they need to involve, because usually it's a multidisciplinary sort of thing. It's not something that just one specialist will be able to take care of, because there are different layers to the help that needs to be given. If medication needs to be given, the psychiatrists have to be involved. We're going to be needing help with the educational bit, like Mrs. Ajosia said. If they need help with social functioning, if they need other kind of help. Some people would have this condition and they are comorbid conditions, like we said. If they are struggling financially, then they might need the social workers to be involved as well. So there will be different layers of specialists that will be involved. But core clinical specialists to be the GP as the first point of call, and then we get the psychiatry team involved.
Thank you very much. So in countries where we don't have facilities, as a parent, I'll be looking for a psychiatrist, I'll be looking for educational psychologists, I'll be looking for counselor, I'll be looking for people like Mrs. Ajosi that are specially trained in that area. Am I right?
I would say, yes, I would say if you're in a country like Nigeria where the care is not harmonized into one, the people that you probably want to talk to if you've noticed some of the symptoms, you can speak to the pediatrician. Within there should be a general pediatrician that can then refer you on to the specialist team, or you can speak directly to the psychiatric team, because there's no GP as the first point of call in Nigeria. You can just speak to your specialist yourself. And if you know any of the other specialists, you might be able to speak with them. But I want to believe that speaking with the psychiatrist team or being referred to the psychiatric team, they can then point you on to the other specialists that you'll be needing, because they work with the psychologists. They might work with counselors as well. They might be in a better position to point you in the right direction.
Okay. Thank you very much. We have a couple of questions here. Somebody said, my daughter will be 5 years next month and she has been having difficulty in her speech. Through my research, I realized that her speech delay and some other traits that I noticed might be caused by autism.
Right. So, like I said earlier, there are a lot of conditions that either can occur alongside with ADHD, or they are the main condition themselves. When it comes to autism and ADHD, it's difficult to differentiate. The symptoms really overlap. And it is the job of the specialist, the job of the psychiatrist, to be able to listen to the child, listen to the parents, observe, and decide what they think is the major condition. Because you can have autism, you can have the ADHD coexisting. It's if you've got your 5-year-old and you're having difficulty with speech and language, please do seek help. Get the pediatrician or get the psychiatrist involved if you're in a country like Nigeria. If you're in the UK, speak to your GP. They will take all the symptoms on board and refer on to the appropriate specialist. It's going to be difficult to just sit back and decide, oh, we think this child has autism. Even for us GPs, we can't take that diagnosis by ourselves, because a lot of layers have to go in. Because when we make this diagnosis, there's a major impact on everything that has to do with the child, with their future. So it's not something easy that we want to slap onto someone. We want to be able to say, without reasonable doubt, this is what we think is going on. And then we can get the right support. Because if autism is the major condition in the background, and we are treating ADHD, it means we are still not treating the appropriate condition. So we want to have a balance to know what is the main issue here. What do we need to concentrate on treating first? So please seek specialist help so that the child can get the appropriate help. And like I said earlier, getting help early is better than getting help late. The earlier we get help for our children, our wards, the better it is for how they integrate into society, how they do educationally, how they end up with work experience and all. So please get specialist help.
Thank you very much. Thank you so much. There's another question that I'm going to rephrase here because I'm sure our guest speakers are not speaking on behalf of the government. So how do we incorporate those kind of people into workforce after graduation? Is there anything in place that support this type of people to gain employment?
Do you want me to answer that?
Yes, ma'am.
Okay, in UK, there's what is called equality and diversity. In the classroom, even in primary, secondary, and college, the first thing we put on the board after we put the learning objective is we are going to be embedding equality and diversity, literacy, and numeracy. So under equality and diversity in this country, in United Kingdom, everyone and everybody can get work. You cannot be told that you can't get work because you have ADHD. We have colleagues, my colleagues where I lecture, that have their own personal issues. We lecturers, as I said before, mental health is in all of us, either we like it or not. But the spectrum is different. So anyone and everyone in this country will get job, and they always create that post for people that have different situations. We have people with mental health, serious mental health issues, but you cannot, because of that, say they cannot work. No, it's not allowed in United Kingdom. So anyone can get job. Anyone can go to uni if they want to go to. There's support.
Thank you very much, ma'am. There's another question that says, how do you know when a child is enduring ADHD? I'll say, Mrs. Ajosekan, how do you know, like, if there's no diagnosis and you have a student in your class, how do you, well, anyway, the question is, how do you know when a child is enduring ADHD?
Okay, I've not done primary education because, as Dr. Wumi said, when you have a child, and like that lady said, the child is 5 years, cannot speak, or what, some situation. Here in UK, if your child can talk, or you are noticing some things that are not okay, your first point of call is the GP, and the GP will refer you. So by the time you have the specialist stepping in, they'll be able to, tell you what the situation is. And if your child is going to secondary or going to primary or coming into college, they will come with their educational plan, as I said before. And that plan is what they carry into the classroom. And when they come, the school or the college will welcome them, because on the application form, we'll have asked them if they have any condition, and they will have written it on it. Immediately, it will be picked up. And you have all these support services within the college just springing up to support that child and make learning comfortable for that child. So there are so many ways that it can be picked up. The only problem are the parents, because of the stigma. They refuse. If you don't ask, you will not get. If you don't tell someone you have a situation, nobody will look you up and think, oh, this person is not well. So you have to tell people, you have to go to your GP, and then you have to ensure that that child has that educational plan to carry to schools so that they can give support at any point in time. Up to university level, there's support.
Thank you very much, ma'am. And when Dr. Umi was talking, she mentioned something that children, maybe ADHD or another condition, they don't have regard for consequences. And what it then means is that in countries where we deal with our children, we maybe punish them, and we are not sensitive to what they are going through. We are not trying to connect. What word of advice from medical and a lecturer perspective will you have for such parents?
I'm just trying to get the question. So I think that was when I was talking about conduct disorder.
Okay, yes.
Yes. Right.
They have no regard for consequences and no sense of time management, So what are the kind of, are we going to say that saying that there's consequences for action, does it matter? Will it change that child? Will it make an impact?
I think just with the ADHD, autism, all conditions need help and support. So if a child is showing signs where they don't have regard for consequences, they're disruptive, they're getting into trouble with authority figures, they're always getting punished for things. In adolescence, they may already be joining peers where they are doing things that are wrong, such as related to drugs and all of that kind of stuff. It's about recognizing what is wrong and trying to seek help for the child. There's especially in this country, in the UK, there's help for every kind of issue. It just, like Mrs. Ajose said, seeking the help, saying this is the problem that I'm facing, then getting the right help involved. If it can be difficult from where we come from, like most of us are Nigerians. We want to probably beat the hell out of the child to get them to behave properly. But sometimes it's just beyond the child. It's just what is driving them is different from what is driving the rest of us. It's about getting to the bottom of things and finding out why is this going on? Why is this child always getting into trouble? Why is this child always hyperactive? Why is this child? What is going what is going on in the background? All can we do to help? And then speaking to specialists that can help, speaking to psychologists, speaking to behavioral therapists, those can be brought on board, and then they can help. I hope I've been able to answer the question.
Thank you very much. Mrs. Ajose, do you have any?
Okay. Thank you. Now, we the parents, especially Black parents, when our children or we have a child that is restless, always jumping, climbing, falling over, running around, we tend to say, what is wrong with you? Shout and scream, slap and beat, sit down, get up, go and face the wall. We don't tend to look at that child and say something is not right here. It might be that we need to find help for this child. Like the lady said that the 5-year-old that can't talk, sometimes we assume it's okay. It's not, because it might be that that child has what is called glued hair. Dr. Wumi, am I right? Glue hair, where they have to do operation, and so that because when the child can't speak, they are not hearing properly. And when they are not hearing, they cannot answer to what you want them to do. And you, the parent, you are frustrated, you are shouting, you are pushing, you are pulling, or you still, calling names. We need to now start to look inward and ask ourselves, are we supporting our children? Are we giving them the best out of life? I know it's difficult in Nigeria. Even people in Nigeria should begin to look and not just say, okay, this child has, label the child. The child might need help. So when you seek help and then they come to classroom, they will have come with, here in UK, they have a statement that has been written about their situation to help teachers to meet their need in the classroom. So they carry that to school, and teachers we equally attend to them. They tend to get more attention. What I meant is not attention of being pushed to one side, or being ensured that they get what they have to get out of education. They do more one-to-ones with them so that they can thrive in their own area. In secondary school, they do the same thing. When they come to college, and that is why in colleges, and not just colleges, even in secondary and primary, when teachers do their CPD, they have to do CPD on mental health, CPD on all these kind of situations that children can come into the classroom with, ADHD, and how you can manage and support them. And in addition to that, we have support team, support staff that will follow that child into the classroom so that they can be doing more one-to-ones with them. Because in primary school or in secondary school, you might have up to 20 something learners in the classroom, and there's one particular child that needs one-to-one. So they will make sure that they provided support that will go into the classroom with the child so that they can support them in terms of managing their time planning. We have what is called skill, behavior, and knowledge. These three things are very important. A child that attends a class must acquire skill, must acquire knowledge and behavior. Part of the behavior, when a child can sit in one place, is restless, you give them break so that they can go out, chill out, and come back and be able to sit down and continue with their work. And you have to learn to break things up in chunks. You don't just give it to them, get on with it. No. And that is why the support staff will be there as well to support that learner to do their work in chunks so that they will get along. If you are traveling from here to, we're in UK, if you are going from here to, let's go, I live in London, you are going from here to Leicester, we have break points that you can stop and rest. For people that cannot do long journey at a stretch, they will branch at these break parks where they relax and then they continue on their journey. And some people, they can do the stretch. So some people will do 3 hours, they get to the destination. Some will do 5 hours and they will still get to that destination. So we have support in place for the learners to meet them at every point of need so that at the end of the day, they all get to the same bus stop. So no child is left behind. I hope I've been able to answer your question.
You have. Thank you so much. And I suppose even in our Sunday school, our children's classes in churches, this will also be kind of helpful because there are some children that I'm sure on Sundays in class, they don't sit down, they run around, and the teacher will be saying, sit down, sit down, sit down. This child has no home training and all that. Am I right? What do you think? Any word, because most people on this platform are actually Christians, any word for, our children teachers in the church? Dr. Omi and Mrs. Ajose.
All right, I just want to add to what Mrs. Ajose has said about the children having blue hair. Earlier on, I had said we have to make sure that there's no visual or auditory impairment. So before we start saying a child is not paying attention, they are not concentrating, have we made sure that they can see? Luckily in the UK, they get to have their eyes revealed at different points, and we can be sure that their vision is okay. But if you're in Nigeria, those are the first things you want to make sure. Can your child see properly? A lot of people still believe, oh, my child should not use glasses. Please, if your child needs to use glasses, let them use the glasses. It's for their good, it's for everybody's good. If you're speaking to the child and you're not sure they can hear you properly, let's be sure, take them to a doctor, let them look into their ears, let them be sure that there's no problem with their hearing, everything is fine. And when we remove the organic issues like that, then we can start saying, is there something else going on? And this would take me to talking about healthy eating, healthy living. I know according to NICE guidelines, it says we don't have to remove colorings and preservatives. We don't have to exclude them from our diet. But other sources have said, especially in the EU, some colorings, some preservatives are not allowed in food. But there, I'm sure in a country like Nigeria, all sort of things are allowed to be put in food. It's about trying to remove. So, so for instance, now we know that if you give a young child a bottle of soda, a bottle of fizzy drink to drink in the evening, they are going to get hyperactive. They want to be jumping around. So most parents would not want to give their child a sugary drink in the evening because then it might be difficult to get them to sleep at night. So it's about just trying to notice, is there any pattern? Is it when I give my child this kind of food that this starts to happen? If you're here in the UK, it's easy to work with a dietitian and then they can have a plan for what your child should be eating. But if you're in Nigeria, you might have to take matters into your own and have like a map. You can write things down. This, if my child eats this kind of food, maybe I start noticing this and that. If this comes into the food, or if my child is giving this particular food items, then they start behaving like this. So we can take attention and pay attention to those kind of things, because what we put into our mouth goes a long way into what comes out of our body. And we eat a lot of packaged foods in Nigeria. There's so many things going on that we are consuming that is actually not fit for humans. So it's just trying to pay close attention to those kind of details. Also, I want to mention that children need to be active. So based on the age, based on their level of understanding, we want to keep them active. If you notice here, if you take your child to nursery, they'll keep them very engaged. They keep them very busy. They let them run around. They let them play very well, and then come back home and sleep at night. But when the child stays with the parents all day long, you want them to sit quietly, watch TV quietly. Don't disturb mommy. Don't disturb daddy. Are we engaging them enough in terms of physical energy? Are we allowing them to express all the energy they have? Are we giving them opportunity to play within in a safe area within their ability, such that when you now want them to be quiet and be patient and attentive, they can't. We can't expect a child to sit down and read their book all day if they are not in that age group. Have we allowed them to be able to jump up and down, to do all those things that a normal child wants to do before we start saying they are restless, they are inattentive?
Thank you very much. There's a comment here. It's long though, but I quickly read it out. Absolutely, ma, you are right. So it's what I like to call structured learning. I have a son who is turning 5 in July. He was so restless in his early years, and I was always asking my husband, who is a doctor, if there was something wrong, probably seek for medical help. And he would tell me, only need to keep intensifying effort and keep telling him the right thing. So sometimes you only need to keep reinforcing to the right way of behavior on a daily basis. And if there are kids that need medical assistance, parents should please go for it. Thank you so, so much. No other question. I thought Mr. Joseph was going to comment on the aspect of the Sunday school, because I know that she's very active in our church.
Okay, how do we handle, what was your question again?
A word for Sunday school teachers, or anyone dealing with children outside the school, maybe other informal schools.
Okay. What I will say to Sunday school teachers, because I myself, I used to be I used to be in Sunday school, and I used to be a Sunday school teacher. Always develop a relationship with your Sunday school pupils, with their parents, so that if there's any situation, if you notice anything, you can discuss it with their parents. Because some parents, they might have not noticed, or they've noticed and they just pretend they can't see it. So you can pick it up and discuss it privately on one-to-one basis with parents, so that they can look into it with specialists. They can let their GP know, that will give them a referral. And one thing I would say also is that as a Sunday school teacher, you've been put in that position for a purpose, because I always see it as a place that God has put you to support and to help kids to learn. Always be kind, be nice, listen, be simple, be clear, be direct. and try to break up things so that they are not doing too much, no coordination. So let it be organized, plan and prepare before, have all the resources you want to use with them at hand. Because as a lecturer myself, I always put planning into place. When you yourself, you are planned, you are prepared for your lesson. Even if a child is not, settling, you will have, we have what is called extension or extra work for pupils that might not be able to do what others are doing. So you can engage that child in a different way and still do what they are doing in the Sunday school. If you are going to read a passage, you can have another one that is designed as a picture or image that child can color, use coloring pencil, because they tend to engage in activity that they can do with their hands. When someone is fidgeting, they can't sit down, they lose concentration. You can't ask that child to be reading a epistle or a whole Bible in the Sunday school. So you have coloring activity so that child will sit down and then they will be coloring using different pencils. So make sure that you have all necessary equipment for your Sunday school to meet the need of all learners in your Sunday school. Make sure that you have rules. Rules are very important, and routine. They know you for it. When you go into if I go into any classroom, they know me. We set the rules at the beginning of the academic year, and we have a routine so that they know that this is the way she likes her things. So they too, they will follow. They will learn to follow you. Allow extensions, as I said before, reward good behavior, and then make sure that fellow pupils don't look down on others. I mentioned equality and diversity. In UK, you don't mess around with it. You let people know that in this classroom, there's what is called equality and diversity. And you are here to learn, to have your skill, to have your knowledge, as well as behavior. Like that lady that wrote there, that the child, the husband happens to be a doctor. Sometimes you tell them, take them to a quiet corner. Oh, the way you behave to so person, you could have been nicer. If you don't mind, can you just go back and try to say you are sorry? It's very important, and that is part of behavior. So that is what I can say. Just make sure that you build relationship. It's very important. Have good relationship with parents and with students.
Thank you very much, Ma. Thank you very much, Dr. Wumi. It's a pleasure having two of you on the platform tonight. We have come towards the end of the program. We just want to have few announcements for us. Oluwatoni Komolafe, are you ready, please? We have few announcements and then we'll be rounding up. Every last Thursday of the month. Yeah.
We are in this together. Join our Facebook group, Blossom Arena for Parents Special Needs Children. The link is there, and please share this page with anyone you know who would like to join. As you can see, we have our Instagram handle, our Facebook handle, and every last Sunday of the month at 4 p.m. Dublin time, we will be here, same time, same link. We also hold monthly prayer sessions for special needs children, parents, and caregivers of special needs. It's going to be the same time at the end of the month each time. Please join us and be blessed. Thank you.
Thank you so much. I want to especially thank everyone that's joined us for this program. Like I mentioned, we have our daddy and mommy Danny on the platform. I have my uncle, Wumi's dad, Dr. Kehinde Shunubi. I have Daddy. I just say everyone on the platform. You are all special. I can see people from different countries joining us. Thank you so much. We appreciate you. And let's just say a word of prayer before we go. And I will ask, please, if Pastor Kunle Daniel is there, can you please round up for us? Sir, thank you.
Praise God.
Hallelujah.
Very, very impactful session. We thank God for our speakers. We thank God for the knowledge you have acquired that you have shared. And we pray that God Almighty will help us, as many as need such knowledge, will be able to also pass that round. Let us pray. Father, and thank you, we thank you, and we thank you. We thank you, Father Lord, for this month session. We thank you, Father Lord, for Lord, your daughters that you have brought on this platform to give insight into what we don't normally know. Sometimes we know the symptoms, but we don't know exactly what is the cause and what to do. Well, Lord, we thank you for this session. We thank you for knowledge you have acquired. We give you praise. We adore you. We thank you, Father Lord, for the visionary of this particular program. We also go for more knowledge, more wisdom, more grace. Lord Almighty God, to affect lives, to touch lives in the mighty name of Jesus. Amen. As we go, Father Lord, we ask that your presence will go with us. Amen. When we meet again, this time next month, let's have Father reason to thank you more and more. We give you praise and we adore you. Blessed be your holy name. For in Jesus' mighty name we pray.
Amen.
Amen. Thank you so much, Pastor Moni.
Thank you, Daddy. Thank you, sir. Thank you, everyone, for joining us. See you next month. Same platform, same time. Thank you.
Bye.
So much. Bye. Bye.
Thanks. Bye.